the main basics of the medical psychology. This is the first topic in the course. Most probably I will be spooked away from this room to some other room, so during the lesson there will be a break during which I will cover the camera while I'm moving around trying to find another place to film, but I hope that we'll have plenty of time for that. Okay, so today we will be talking about the subject, objects and methods of the psychological study of the person, also concepts of mental health, since it is medical psychology, and also the set of mental functions and disease. So the basic disorders which we can see in the psychic sphere without going too far, because you are not a psychiatrist, you are a psychologist, so I won't be stopping in details on the psychopathology, only on the basic things you need to learn. If you work with people, you will have to use practical knowledge of psychology. It is very sad that in our university, usually this study is regarded as unimportant or understandable by anyone, or not a science, and a variety of other definitions. This is far from the truth. Psychology is a very serious subject. It is about the structure of our psyche, about its functionality, and practical branches of psychology have a direct influence on how you do your work when you interact with people. Some of us are better at psychology, some of us are worse. Personally, I had an uneven development in this field, so some skills are much more enhanced comparable to the average population. Some skills are far beyond the lower threshold of a usual person understanding another person. But all of these can be practiced, all of this can be learned. So do not be frightened if you are not a good empath, or if you feel that you never understand how other person thinks and feels, because everything can be trained. There are people who study this, and you are here to study it with me. So everything will be fine. Medical psychology is needed in all fields of medicine, because you can be a good practitioner in the medicine, but you will be not a very good communicator with other people, and psychology helps us in the communication with our patients, and it will affect the treatment of your patient, because it affects compliance between you and the patient. So we'll be talking about this in a minute. So psychology literally means the study of the soul, because psyche, our production of our nervous system, our activity, is the synonym for the soul. And we also talk about development and manifestation of the mentality. When we're talking about mentality, we are talking about the product of the development of us as a living substance. Subjective image, it is the subjective image of the objective world, which serves for orientation in the surroundings. So mentality can manifest by a variety of things. For example, there are mental processes, and these processes are mostly automatic. So the cognitive view, cognitive processes, emotions view. Then there are also properties, and these are psychological features of personality, which make us distinct from one another. So, for example, our temperament, character, or abilities. And there are also conditions, which are short-term, temporary dynamics of mental activity, which influence our behavior. For example, mood, stress, etc. Psychology can be divided into general, individual, social, and also a variety of other sub-branches. When we are talking about medical psychology, we are talking about a sub-branch of general psychology. General talks about the general structures of our psyche and how it operates. Individual talks about one person, so usually it's also called in psychology of individual differences. And when we are talking about social, we are talking about phenomena arising in groups of people. Okay, so what is the difference between the usual psychology and medical psychology? Medical psychology deals with the way the ill person thinks and operates and feels, about how their psyche reacts to the illness and how it influences the main cause of the illness. And we are not just talking about illnesses which are of psychiatric origin. So not only mental illnesses, but also somatic ones, because any person who is ill, you know that they will alter their behavior somehow. There will be a unique spectrum of emotion they feel during the illness. And so it's our job as doctors to tackle these questions as well. Not only to refer to the clinical psychologist, for example, if we need to, but also to understand ourselves, how this works and how this manifests in our patients. Okay. There's always a system when you interact with somebody. This system may be between the patient and the doctor, between the patient and the nurse, between the nurse and the doctor, because you know the doctor may not be able to take the tasks of the nurse onto themselves, but they should understand, should know how to do those tasks and how to explain the nurse how to do them. And also the nurses are usually the base for the doctor, and these people, nurses, they are amazing. A very qualified, experienced nurse, I would say, in my opinion, is worth 3 unexperienced doctors. So they're very knowledgeable, they are very reliable, and they cannot be replaced during their medical treatment. So nurses also come into this system. And important factor, which is often omitted, is that patients' relatives are also part of the system pertaining to the treatment of the patient. Why? Because when there is a system, each element has its own role. If an element is characterized a certain way, this means that it has some connection to their role. So here we are talking about system relations a little bit, like family systems, like other things relating to systems. So, for example, our patient who is ill, they're fulfilling a certain function in this system by being ill. If you want to alter this, even if the patient is completely compliant with this cause and they want to get rid of their illness, this means that once they're changed as an element of the system, their function will change. And so the previous function, if it is not deactualized, it should be taken over by other members of the same system, because this function should be implemented, should be realized. And the problem is that sometimes relatives of the patient actually do not want the patient to become healthy. And this is extremely evident when we're talking about mental patients, because usually their illnesses have a lot to do with both the internal factors and these pertaining to their genes, pertaining to their family system, and also the environmental factors. So they are a very important member of the system. But also this relates to the somatic patients. So in the mental patients region, I would say there was, for example, the case when in the admission ward, there was this little boy who was 12 years old, and he was hearing voices for the past year. He ran away from his house because those voices commanded him to kill his parents, and he didn't want to. So he was at first suppressing them, but then he just stopped and he ran away for the parents not to be heard. So when he was caught and he was telling all this to the doctor, there was his father sitting right next to him, and the father became outraged. And he started shouting that you are telling the lies to the doctor, this doesn't happen to you, etc., etc. So this was a normal reaction for the father. For the first reason is that the father is in denial. They don't want to admit that their child has a serious problem. The second thing is that they probably feel guilt when they think about this illness, because all parents think at first that that's something which is the result of their actions or something in their control to do for the child. I wouldn't lie, a lot of illnesses, of mental illnesses of the children arise from the actions of their parents, but not everything. Not all. The parents are not the devils in this situation. We are not here to find who is guilty and who is not. We are talking about the child having a problem which we want to solve, want to help to solve for the parents. Yes, all guilt. And the third thing is that the father didn't want the system to change, because if the child gets cured, then the father should adjust their behavior as well for the child not to relapse. And nobody wants that. An example in somatic disease would be, for example, patients with diabetes mellitus who follows the recommendations of the doctor, follows the diet, restricts themselves as much as they need to control their illness, but then they attend the party of their family members and their wife is like, don't you respect my mother? Why don't you eat? Why don't you try her cake she made for you with her love? Just a little bit, just one piece. And this diabetic, he breaches his diet and then arrives in a comatose state to the intensive care. So once again, both in mental disease and in somatic disease, this oppression from the, not oppression, but let's say defense against the treatment is evident, and you shouldn't be surprised to see this. First of all, we see this oppression from the patient when they don't want to take their pills, and when they actually take the pills, it's their relatives who step forward, and they take this turn to struggle against the treatment. Okay, so here is that. Okay, so tasks of medical psychology. So what it does? It evaluates the patient's specific features and changes of their psychological functions under the influence of the illness. Also analyzes the role of mental effects in causes, duration, and prevention of psychosomatic diseases. And we'll be having a whole lesson dedicated to psychosomatic diseases. Also analyzes the personal and professional psychological peculiarities. Also studies the interrelation between the patient and the doctor and the nurses, so corporative ethics as well. And also works out the principles and methods of experimental psychological examination, correction, and psychotherapy. And that is very interesting about psychotherapy, because psychotherapy is regarded by many as a part of psychology, but actually psychotherapy is a practical branch of philosophy. It is a philosophy. And any action actually can be psychotherapeutic if you know the goal you try to get from this action, and you know what you're doing. So in the hands of a very skilled psychologist, anything can be psychotherapeutic. But we are rambling once again. So now, sections of medical psychology. So you already know that psychotherapy is not a section of psychology at all. It is a branch of philosophy, practical branch. So medical psychology also includes psychology of patient's behavior, self-explanatory. Also neuropsychology, and there is also such thing as neuropsychiatry. So neuropsychology talks about where exactly in the brain there are certain psychic functions. For example, where is the memory, or where is the sensation located, such stuff. There is also psychoprophylaxis and psychohygiene. So psychoprophylaxis tackles the prevention of psychological disturbances in any medical cases. And psychohygiene is a certain, I would say, lifestyle, which once again diminishes the risk of negative impact on the psyche. A practical example would be, for example, in Ukraine, we have very bad psychological hygiene. You can have a friend who constantly complains how everything is bad in their life, how other people are evil towards them, how everything wouldn't be better anytime soon, etc., etc. And they are making you feel bad, actually bad. And that's not from the standpoint that, oh no, I just don't want to admit that we have these problems. No, this is just a lifestyle for this person who just uses you to complain about stuff, to just throw away the burden they have onto you without your consent. This is poor psychohygiene. Another example of poor psychohygiene would be there is the Lodo family in my city, in which it was perfectly normal for the members of this family to walk around naked in front of one another. But the problem was that the two daughters in this family, while they were little, it was kind of fine. But then they grew up, and they were like 28 years old, and they were still walking around naked in front of their father. You know that there is a taboo on incest, of course, and consciously nobody would admit it, but the father was getting aroused by his daughters. And this atmosphere, because he was, of course, trying to suppress this tension inside of him, And the daughters obviously felt this, even though they weren't conscious about this. This would impact their behavior and their psyche in the long term, because it is a certain tension which is suppressed from both sides. But once you suppress the tension and you compress it more and more and more and more, at a certain point it just explodes. So that's poor psychohygiene. Then there are two things: pathopsychology and psychopathology. So what is the difference here? When we are talking about pathopsychology, we are talking about pathological psyche. Pathological psyche. So we are talking about the peculiarities of functioning of the psyche of people who are mentally ill. For example, how schizophrenics think, how the brains of epileptics work, such stuff. When we are talking about psychopathology, it is psychic pathology. So we are talking about elementary disturbances of psychic functions like amnesia, hallucinations, and the disorders it has. Then there is psychodiagnostics. So psychodiagnostics is related to the methods we use to measure objectively psychic functions. For example, how good the memory is, or how bad is the attention of a certain person. And you may know these psychodiagnostical methods as a psychiatrist, for example, and I'm a sucker for psychodiagnostics. I love it. But your conclusion after the psychodiagnostics, if you try to do it yourself, wouldn't be valid, because the procedure is that I need to consult a clinical psychologist who comes and does the test themselves, and I only direct them which field of the psyche they need to test. And only their conclusion will be regarded, their psychological diagnosis would be regarded as valid in this situation. Because I can tell everything I can, but I'm a psychiatrist, not a psychologist. So that's the procedure for this, unfortunately. Or fortunately, depends on the case. There is also criminal psychology. A lot of people who get into jails have certain peculiarities of their personality, and knowing these peculiarities, we can find new ways how to prevent this breaching of the law from happening, and how to rehabilitate these people in the society, because many of them may not know other ways of satisfying their needs and drives apart from the illegal ones, but actually all of these guys want something, and this something isn't the crime itself. Sometimes it is the emotion, sometimes it is some goal they perceive, they try to prosecute by this. So that's why we have criminal psychology. Also, there is psychology of health. So basically, how the healthy person thinks, how the healthy person organizes their life in order to remain healthy, and what is health itself. And also psychosomatics. Psychosomatics is a branch of psychology about illnesses which lose the connection with the consciousness and become manifested as the disruptance of somatic functions. But these somatic functions, usually, these disruptances usually do not correlate with complete certain illnesses. So we'll be talking about those. We have a whole lesson dedicated to psychosomatics. Also, what I need to mention, and I tell this on each first lesson of medical psychology or of psychiatry, this is the difference between norm, pathology, healthy, unhealthy, good, bad, and also probably useful and useless. But no, correct and wrong. Yeah, correct and wrong. So what is the difference here? When we're talking about something correct or something wrong, we are talking about whether the person reached the goal they had set for the certain action they have done in order to get the goal. So, for example, if you are telling me that you want to get healthy, but you ignore my recommendations as a doctor, you are doing something wrong. And if you did not want to get treated and you avoided being hospitalized, well, you did the correct move because you reached your goal, you have set for yourself. We are not judging whether somebody is correct or wrong if it has no relation to the treatment of the patient. So, Of course, yes, I need to criticize the patient for not following my recommendations when there is a danger for their life, for example, or for the lives of other people around them. But like, not in scolding them, but I need to use my medical psychology skills in order to convince them why this will be useful for them. It doesn't always happen, doesn't always work, and this depends for a variety of this depends on a variety of factors, and probably we will be talking about those in the next lessons. I don't remember because most of this course was recorded 1 year ago, and I need to redo everything again. Okay, then norm and pathology. When we regard something as normal, it means that it is a frequent occurrence in the population, and pathology is something which is rare. Something which happens often may be unhealthy. For example, a lot of people eat fast food. It is unhealthy, but it is very common. So it is a norm for many societies to eat junk food. Or for example, being perfectly healthy will be rare, and therefore I would say even a pathology sometimes. Especially, for example, if you attend meetings of sectarians, and they ask you, why don't you become a fanatic of a certain god? Like, it is normal in their group, but you are the pathology there if you do not share those views. Okay, then good or bad. It is mostly about the law, and it is mostly about not even the law, I would say, but about ethics. So about morals, and this depends a lot on the society we are in. So doctors do not put labels on people that patient is good and that patient is bad. That's not what we decide. We shouldn't even think about this. And if you have seen the news, for example, for Ukraine in this year, on the war, many of our doctors treat both sides because we are not judging who is good or who is bad. I can have my personal opinions on these issues, but when I'm working, I'm an instrument which helps other people to become healthier. So I do not look at these differences. If I'm not at work, obviously, I would be much more aggressive. But when I'm working, I'm impersonal in this regard. Okay, so this is another thing. I'm telling you this because this sets a certain mindset for the future of you as a doctor, so that you will be much more unbiased towards your patients, especially if you work in the mental field. I have seen a lot of psychiatrists disregard their patients, and this is not because all of us are unprofessional, something like this. A lot of us are scared of becoming mentally ill, and therefore we try to project our anger onto these patients who remind us that we always have a risk of becoming ill, especially for psychiatrists. But I will be talking about that in the other lessons probably. Or if you would like to ask me personally, I will gladly reply in the comments or in the letters or in the messages. It's best to ask me in the letter. Okay. And last thing, healthy or unhealthy. So how do we even include something in the classification of the diseases? We need to have a lot of people coming with a certain condition, which most often causes these people, and we judge this often by the amount of people who complain of this symptom, which causes these people to become decompensated in their lives, to lower their level of life, to cause them problems, to cause them distress. In Russian, the word illness is pronounced as болезнь, and it has this part in this word called bol, pain. So illness is painful for the person, either on a functional level or in the subjective level or in the objective level. So usually on all of these levels. So if you have enough people presenting with this problem, we say, okay, most probably this is an illness, because it is very likely if you get this condition, you will feel bad. So let's sign it as an illness into our classification. It is possible for the person to not feel distress from the condition which is described as an illness in the classification, because for the majority of people it causes problems, but you may be the minority, which is adapted and compensated. If talking about mental illnesses, especially mental illnesses, because our psyche perpetuates itself in all of our fields in our life, most often the cure and complete, I would say, yes, complete health from a certain illness is not the absence of the symptoms. It is not the absence of the illness or the condition which caused it. It is the mere adaptation of these mechanisms when they do not cause stress for the patient, when they do not make the life harder, when they do not spoil the life for you. What you need to understand is that each illness is a certain function which our organism is able to do. You get symptoms, for example, from the organic impact of your organism, not just because you had that impact, for example. Yes, for example, you have broken a leg and you get pain. Pain is not the actual thing coming from this fracture. It comes from your nervous system being able to sense that something is wrong, that it is sending you signals. So the pain itself is not a bad thing. It is a signal for you. It becomes a problem when it is a constant pain and the patient already knows what caused it, just cannot get rid of the reason, but it is still painful. So that's the difference. What I was talking about. 1 minute. Yes, adaptation. So, especially if we talk about psychosis, which are very severe mental illnesses, it is usually an extreme defense of our organism directed at saving the life, even though most of the times it may even get you rid of your life, because it becomes an illness when it is chaotic, when it is uncontrolled, when its initial function is already obsolete, but this process is just so deeply ingrained that it just keeps going. So our task as the doctors to make it controlled, to get rid of these, not to get rid, but to not to prevent these most dangerous side effects of this skill the person has, the skill of their nervous system, of their organism to develop certain conditions, like the febrile temperature during the infection, which is once again a defensive mechanism of the organism. We should weaponize it. We should make it a skill and not an illness. Okay, I have talked about the differences between categories. So now let's proceed. So how do we examine our patients psychologically? Well, obviously, first comes observation. We should observe, I insist that you observe your patients on different occasions. When they are with you, when they are by themselves, when they are in the group of other people. Because those 3 occasions may have 3 different behaviors and not always in the borders of the norm. So most of the times in the borders of the healthy norm. Most of the times you may see symptoms of an illness manifest only in one of these occasions or in all of them. And this will signify different reasons for this condition for you as a skillful doctor. Also, when you interview, so clinical interview, when you, too early to talk about the interview, so you are still looking at your patients, you're observing them. You can get a lot of information just from seeing how the patient is dressed, how the patient is moving, how their voice sounds, how their eyes look, their emotional expression on the face, their non-verbal expression. And you shouldn't overlook their appearance, because one of the most earliest signs of many mental conditions is being unkept. The person stops caring for themselves, stops combing the hair, they stop eating in time, so they lose their weight, they lose their sleep, or they purposefully do not sleep, they start mutilating themselves, for example. So you may hear the smell, you may smell foul odor coming from their body, for example, so they haven't bathed for a very long time. And the person may not exhibit psychopathological symptoms just yet, but you already see this social unkeptness. And this is a sign for you. This is a sign that something is going on with the person. Okay, now clinical interview. So you are talking with your patient. In psychology and in psychiatry especially, we need to have two versions of the interview. Subjective one, when the patient is telling us something, and objective one, when we are interrogating their close relative or friend or somebody who knows them. Because, you know, people can lie, people can be oblivious to see certain things because of many reasons. People may have a false impression of what is going on with them, and everything of this is important, and you need to be able to evaluate that. Okay, then there is experiment. So you may modulate certain conditions for the patients in order to see how they react and how their psyche functions in these conditions. And also psychodiagnostical examination, when we use questionnaires and tasks for these patients to perform and to give you the result, when we can measure mathematically how the functions of the psyche work. And also, often this thing is omitted, but I would rather not omit it. It is analysis of the patient's creations. Basically, all things we create are the projections of our psyche. We project something onto our art and our activity. And so these creations can give you a lot of information about the patient. In the word of the first psychosis episode award, there was this woman who was admitted to the hospital because she believed she was the reincarnation of the mayor of the city, and on this behalf she demanded in the restaurant to be serviced for free. So she was brought to the hospital. She was there for a long time, and I conducted an experimental research on her. She had to complete Dan Boramenstein's unfinished proposals. So those are the sentences grouped into certain topics, for example, family, friends, sex life, such thing. And the patient should continue those, given an answer to the certain questions. So I did this on her, and a lot of her worries were connected with the family. And then when I was looking through her case history, I was told that she writes a lot of letters these days, and these letters get thrown out to the bin. So I rushed to the dumpster, got those letters, because apparently nobody but I was interested in them. And so in those letters, I have seen that she, as a mayor, was making a lot of statements and demanding to make new laws in order to help everyone in this city. And among those laws, apart from the delusional ideas, there were things like the good husband always keeps his wife happy. Or, for example, a good wife is always smiling. She has a lot of time to make herself pretty. She has time to rest. She has a lot of friends, stuff. And a lot of was connected with her husband. And I knew from her case history and from talking to her that she is actually divorced with her husband. And she had a lot of conflicts with him before she got this first attack of psychosis. So obviously her psychological conflict was reflected in those letters, even though this wouldn't influence directly the treatment when we are talking about medical treatment in psychopharmacology, so when we are using medicines. But in the way I talk to her and in the way which arguments I use in order to help her to adaptate with your illness, this would be affected by the things I saw in her letters. So do not throw away things your patients do. It may be very important. Okay, I have talked about this and about this. I'm just looking through the presentation in order not to miss anything. Okay, about this and about this. Okay, clinical interview. Well, you have other clinical courses, so I won't be describing what are the principles of clinical interview. You know those yourself. Unfortunately, if I had more personal space here, I would go into the details, but unfortunately not today. That's why I most probably need to rework these courses next year. Yeah, about experiments. So experiments can be divided into a natural one, when the surroundings are the usual ones for the patient, and laboratory experiments, when all the conditions are created artificially. Okay, so there are certain stages to this experimental psychological examination. So at first it is preparatory stage. You need to prepare your materials, which you use to experiment on your patient. Then there is proper experimental, so when we are doing the experiment. But while we are doing the experiment, we get raw data. And this data cannot be just read like this. So there is quantitative processing of the findings. And we get numbers, we get formulas, we get equations, such stuff. So we need to interpret this received data and then derive the conclusion, psychological diagnosis. And that's why I told you that psychology is a very serious subject, because many people think that it is about talking to people and study them, but nobody knows. Nobody thinks that we study them by making them into numbers and then explaining them once again. Okay, there are different levels of psychological diagnostics. It may be symptomatic and empirical. So, for example, we see by the numbers that the person has a lot of sadness. That's all. Then it may be etiological. So, I not only say that the person has a lot of sadness, but I say that the person experiences sadness because of their depression. So, it is the etiology of the symptom. And there may be a typological level. So I say that the person experiences sadness as a result of their depression because of the organic disease of the nervous system. So it is typological here. Okay, so psychological diagnosis can be objective and subjective, and also projective. Projective means that the patient is creating something which reflects their inner life. Psychodiagnostic methods, I have mentioned them. They can be divided into tasks. For example, 5 plus 4 equals is a task. And questionnaires, which only have a bunch of questions and the patient needs to answer them. Most popular ones are the personality questionnaires, and there is a bunch of them. Some of them are not scientific at all, like socionics or Claspects, or what else? Or MBTI. A lot of people love MBTI system or Enneagram system, but they are not scientific, and there were actually studies which proved that there is no correlation to specific traits which are described in these types. But these types were designed a certain way to make the person believe that it is about them. It is a illusional simplification of the complexity of our personality and our psyche. You cannot group everything into types, unfortunately. It sounds very delicious, it sounds very seductive, but no, it doesn't work like this. I love classifications myself, so it is a very big pain for me, but I know that it is impossible. Okay. So, main areas of mental activity include cognitive, which can be divided into perception, memory, and thinking, also emotional and volitional affectory. So, how we move, affectory, and what for we move, volitional, our drives. So let's start with the sensation and its disorders. I wouldn't be stopping on the physiology of these processes because you already had pathophysiology, you already had normal physiology, but I'll be talking about the main differences. So just so that you know, you will remember. Where is the thing? Okay, I don't have anything here. Oh, yes, I have it. Okay. So here I have a brush, and for example, I can see that it is green. So it is the sensation of the green color. Sensation is the most elementary act which can be used in order to identify certain objects. So I get a sensation that it is green. I can see this color. Then there is, for example, perception. Perception is the combination of sensations. So, for example, this object is green. Also, here it is soft. Here it is firm. It is of a certain size, and also it is very fluffy here. Also, here it is very cold. So, out of these sensations, I say to you, this is the brush. This is the perception of the brush. I see it. Once it is out of my field of the vision, I do not perceive it anymore. But I can remember how it looks. And this is called representation. So when I remember the previous experience of perception of something. And then if you tell me, ask me, for example, to combine this brush with a hedgehog, and I may think of a brush with the needles on its side, this would be an imaginational act. So I'm combining two previous experiences into something new. That's the difference. I'm talking about these differences because the difference between illusions and hallucinations and different types of hallucinations is usually akin to the differences between sensation, perception, and representation. Okay, physiology, I have talked about those, so you remember which kind of sensations there may be. And don't forget about interoceptive. It is usually a common belief that we do not actually feel what happens inside of us, apart from the cases when the person is hypochondriacal or when the person has synestopathy, for example. Synestopathy is a very difficult to bear sensation in the body. But actually, our emotions are combinations of these interoceptive signals. So when the person suffers from a lot of different interoceptive signals which cannot be interpreted by the organic origin and they do not understand what they feel, usually this is the problem of the combining these sensations into one certain emotion, because the person doesn't want to feel this emotion. So do not forget about interoceptive things. People with mental disorders, for example schizophrenics, may become too sensitive to interoceptive signals, to the ones which should be suppressed and remain in the unconsciousness. For example, they may feel how the blood goes throughout the body. So that's an interoceptive signal. And they may attribute this to some delusional idea, but actually this is a normal thing to feel, but usually you're not conscious about this. And the problem here in the illness is that you become conscious of it. So that's about sensations. Perception, I've talked about this. Also, there is auditism. So what is auditism? Auditism is when the person's representation of a certain experience is as vivid as the real perception. So if you try to imagine something in your mind, you may see that this image is usually very bleak. It lacks certain details. Still, it is rather an idea of a certain perception than the real perception. So people with auditism, they can have identical memory, for example, photographical memory. And this is not a normal thing. It is not common, but it is a very useful skill for many people. Okay. So what can happen with sensation or perception? On the very basic level, what can be wrong with the... what is here? Okay, I see. So what can be wrong with the sensation? Overall, I need you to understand that any disturbance can be divided into the elevation of the function, the diminishment of the function, absence of the function, and its distortion. So when we are talking about sensations, when there is too much of sensation, we're talking about hyperesthesia. So the person is just too sensitive to something. For example, the person who is very tired may be sensitive to the stimuli of light, may be irritable by it, or sensitive to the sounds, such stuff. Also, when the person is influenced by drugs, for example, they may be hyperesthetic to the touch, to the smells, to the sounds, and to the pictures, to the colors. Okay, and there may be hypoesthesia. So there is hyperesthesia and there is hypoesthesia. When we're talking about hypoesthesia, it is a diminishment of the sensitivity. And it can happen not only in the mental illness. For example, I have had this patient in the kids ward who was suffering from depression, and he was admitted for the 7th time when he tried to slash his neck, and he had a lot of deep lacerations all throughout his hands. So I asked him how did he manage to do those? Because like I will get scared if I try to damage myself like this. And he told me that, you know, my emotional pain is so strong that when I try to slash myself, I do not feel anything at all. So he was hypoesthetic. Also, in somatic diseases, my father, who's an endocrinologist, he told me of this case. His patient was walking around during the summer vacation at the edge of the pool on the tiles, and he had diabetes, mellitus, and he heard people screaming. When he turned around, he understood that he was leaving bloody trail because his feet had burned down on the hot tiles, and he didn't even notice because he was hypoesthetic because of the death of his nervous cells. So here is that. Now, when we are talking about different distortions, there may be, for example, illusions. So when we are talking about illusions, those are the perceptions of the real objects which are wrong, which are distorted, and which substitute the real stimuli. So what I mean by that? For example, you may look at the glass of water, and you may see that the spoon bends inside of this glass through the water. This is the physical illusion because of the properties of the light. And you are not seeing both the bent spoon and the real and the unbent spoon, but only the bent one, because the illusion substitutes a real stimulus. So that's the illusion. Illusion is also sometimes influenced by our mood. For example, when we are talking about affectogenic illusion, so a child who expects to see a monster under the bed will see this monster in the toy they have forgotten under the bed. So here is that. Also, illusions can happen when the person is intoxicated. For example, paradoric illusions, when random objects form a pattern which resembles faces, figures, etc. So here is that. There is also synesthesia. So what is synesthesia? Synesthesia is when sensations from one analysator irradiate onto another analysator, and you may get a simultaneous sensation from both analyzators. So for example, the person may have musical synesthesia, auditory synesthesia, when they hear music and they see colors at the same time. I have gustatory synesthesia. For example, I see objects and I can feel the texture of this object in my mouth. Sometimes it is very unpleasant. Sometimes it is very useful when I'm talking about people. So such stuff. And it can happen in any analysator. Also, now let's talk about hallucinations, itching, and paresthesia. So paresthesia is the feeling you get, for example, when you spend a lot of time in a very uncomfortable pose. So you have this unpleasant sensation. Itching is the unpleasant sensation which goes away once you touch the stimulated part of your skin. It may be caused by intoxications, for example, by urine in your blood, such stuff. And hallucinations. Hallucinations are false perceptions which occur without substituting a real stimuli, and usually they are not connected to the real stimuli. So, for example, if you hear voices in the rustling of the leaves when there is wind, but you do not hear the leaves, you hear the voices in them, it is the illusion, because this perception substitutes the real one. But if you hear simultaneously both the leaves and the voices in them, this is hallucination. Hallucination can be triggered by certain environments. We had this patient who was convinced that his neighbor is knocking on his walls. And when he was in the hospital, nobody was knocking. And but we couldn't discharge this patient because once he goes home, this knocking would resume because it is bound to the environment of his apartment. Something wrong is very wrong with the place he lives in, with the conditions he lives in, and therefore he may become even violent towards his neighbor. So here is that. Also, hallucinations can be divided into true hallucinations and false hallucinations. And the difference is that true hallucinations, they are much more lifelike. They are projected outwards. And this means that, for example, when I turn away from them, this hallucination, for example, if it is auditory, no, not auditory, but visual one, yes? hallucinations, just like illusions, can occur in any examples. So if I turn away, I don't see this hallucination anymore. Then I turn back and I see it. So that's a true hallucination. True hallucination obeys laws of physics. So true hallucinated images do not go through walls, for example. If a person which I'm hallucinating is sitting on the chair, then if I try to knock the chair out of them, the person will fall. Of course, the person doesn't exist, but it obeys. This person obeys, this hallucination obeys the laws of physics. So that's the difference. Also, true hallucinations are very hard to influence by view. So what I mean by this, when the alcoholic who is hearing voices commenting on his habits during the alcoholic or hallucinosis, when they try to talk to the voices do not reply back. They just go on and on and on a certain fabula, which is, of course, influenced by the mood of the patient. So here is that. And when we are talking about pseudo-hallucinations look fake. They are stamped onto reality. So, for example, if I say that I can see my mother walking around behind my back, I'm talking about actually seeing her. This is called extracamping hallucination. It is pseudo-hallucination because I cannot physically see her. I am not turned around, but I see her right there. So here is that. These hallucinations do not obey laws of physics. If I see, for example, a face stamped upon the reality and I try to turn away, the face turns with me. Also, they may go through walls, go through other objects. If you're talking about voices reply back and become affected by your actions and by things you say. But what I need you to understand is that auditory hallucinations, which are pseudo-hallucinations, are usually not complete sentences. Even if the patient claims that these voices tell you, for example, to do something, most of the times these voices do not utter actual words. So what I mean by this? There was this case when one of the patients was hearing voices, but he still had some critics left, and so he told that at first he got scared because those voices were talking about some crime he committed, and he thought that this was real. But then he tried to listen in to what they actually say, and he understood that they are actually mumbling, and he cannot hear full words and full sentences, but he has this conviction and this emotion of fear because somebody would blame him. And so he projects what he wants to hear in this mumbling, just like, for example, old people do when they have bad hearing. They become paranoid of you because they do not understand what you are saying, and they are hearing in your mumbling things they want to hear based on their emotions. I have experienced a variety of hallucinations in my life because I'm dumb and I do not sleep enough, especially when I was a medical student. You know how I feel. And so when I was a medical student, there was a case when during the lecture I was underslept, severely underslept for many months at that time. And everybody was sitting in the white cloaks and wearing white hats, me included. And I was looking at the students sitting beside me, like below, on another desk. And their hats were all wrinkly. And in those wrinkles I saw faces. I already had visual hallucinations before that, and so I knew that this just means that I'm very tired, and do not be scared, like a variety of people who are mentally healthy can get hallucinations from being intoxicated. So intoxication from not getting enough sleep is another case of that. So I was used to those hallucinations, so I didn't get freaked out right away. But then I heard those hats talking, and one hat was telling another that they will kill me with an axe after the end of the lecture. I was very angry because naturally, like, some hats want to kill me, and I was looking at them very angrily. And then they had stopped talking, and one of the hats told another one that, you know, I think she hears us. So I was even more freaked out. But later on, since I wanted to become a psychiatrist from the very first course of the university, I started to think, okay, that I understand that the very fact that I see that I heard that, it is due to my intoxication. So I know about etiology. But why such content? Why actually the persecution of delusion here? So I was thinking about this, and I understood that because I myself am a very aggressive person, I most probably just projected my aggression onto those heads, and therefore the speech had this content. So you need to understand that emotions of the patients influence their voices, their visions, and you need to take this into account, for example, because a lot of doctors make a mistake when they talk to the patients and they talk to them aggressively, or they feel aggression towards their patients, even if they suppress it. This tension can be felt physically, and the patient who is inhibited in their impulses, they will react immediately to this. They will not tolerate this, and if they feel that you are a danger to them, they will punch you in the face, most probably, because once again they will react immediately. So that's why a lot of patients of mental hospitals, for example, they have a reputation of being unpredictable. No, they can be predictable, because you know that this mechanism, they attribute something they feel to the most appropriate stimulus around. So if they feel that somebody is persecuting them, and you come into the room being aggressive towards them by your emotions, the patient will attribute this feeling to you and will react. If you are calm, the rate of this occurrence becomes lower. Of course, there is no absolute defense and no absolute safety in all of the cases, but I guarantee you that this helps if you just behave as a normal person with your patients, if you respect them. Another example of this would be, for example, I had this senior colleague back in my hospital when I was an intern, and he was walking around and showing me the ward and like teaching me how to talk to patients. And we were on the observational part where all the violent patients are kept. And he told me that, I was suffocated here 5 times, but I don't know why. I immediately became tense because, okay, so this means that maybe I will be suffocated as well, because I'm a very little woman, so anybody can help me basically. And when we came into the room where there were criminals, so people who were admitted here by the court because they have killed somebody already, this was one of the worst rooms, because once again these people do not look after themselves, so there was a certain smell, there were feces in one of the corners, so it was very rowdy. And when I came there, for me personally, it is not a problem of smelling something, because I can easily substitute my sensations. I'm a very suggestible person, and I studied hypnosis for a certain period of time, so I know what to do when I want to shut off certain sensations. But my senior turned to me and told me that, you can cover your nose if you want, because they stink. And I saw that everyone in the room was gazing at him. They heard him. And their cases weren't very good. They actually were planning to suffocate him once more. And they will do this again and again and again, because he has a certain attitude towards them, which is stigmatizing, which is disrespectful. They may have problems with their hygiene, but this doesn't mean that they are unconscious about these problems. Most of the times, the mental patients do not have the correct attention to focus on keeping up the appearance, or for example, they do not have energy to do this. They know this thing. They don't like it either, but they don't like your attitude even more if you behave like this. Okay, so please don't be such doctors. Yeah, also I forgot to tell another very important thing. So I have noticed that a lot of students, even the ones who have studied medical psychology before, interns, they don't know how to talk with people, how to speak with people for the first time. So there are tricks how to gain the trust of the patient you see for the first time. There is a variety of tricks, mainly 3 ones. 2 of them are easy, and one is very difficult and needs to be practiced, but is one of the most effective ones. Okay, so the first trick is just breathing in unison with your patient. How this works? The patient tries to identify with you, and if you breathe at the same rate with them, you are psychologically adjusting to your patient, and this makes it easier for them to identify with you. In a lot of people who are deemed unsuggestible, for example, for hypnosis and stuff, who are very, I would say, unmoving in their principles and beliefs, I can find them very easy to influence, actually, if I use this technique. Because the problem is that when they cannot trust you, they are very tense, and therefore any influence from the outside, especially direct one, if you are giving the person the recommendation for the treatments and stuff, it becomes very hard to be accepted because the person is tense. All the suggestions, they come through when the person is relaxed, so you need to relax your patient. And once the patient identifies with you, they start trusting you, they start to relax, to open up. So that's how it works. The most strong psychological adjustment is actually having an intercourse with your patient, but I wouldn't recommend that, and you wouldn't want to do this either, in the majority of cases. I have heard many stories from some of my colleagues that there are different cases, but still, breathing is easier. Breathing doesn't give you AIDS, at least. Okay, so that's about breathing. Also, mirroring. So when you are seeing your patient and you are talking with them, to them, mirror their actions and their movements. But it is not monkeying. You shouldn't mirror everything exactly. You should copy, I would say, the vector of the movement. So, for example, the patient does something like this, and you may do something like this. So it is smaller in intensity, but the same vector of movement. And this, once again, makes it easier for them to identify with you and trust you. And the last trick, which may seem magical to everyone and very hard to do for the psychopaths, but since I'm a psychopath, I was even trained for this for a very long time, and actually, I would say it is doable if you train this skill. So this is called Substitutional perception method. In our brain, there are mirror neurons which help us to employ empathy. Usually, for the majority of people, these neurons work automatically. For someone better, for someone worse. Usually, people who are very good empaths, if they become subjectively, they become consciously good when they are able to feel their own sensations. So when they're in touch with their own body, when they are not repressing their own emotions, then they may feel other people as well. So that's one factor which contributes to this. And also these neurons. So when we are talking about inborn ability to be an empathetic hormone. But this can be trained. And so if you are a psychopath like me and you don't know what other people feel, you can train this ability. So how this works? Since it doesn't work for you automatically, we need to direct our attention to the processes in our brain which contribute to this ability. So when you see your patient for the first time, you try to relax as much as possible. So we are reducing this factor when we are tense, which makes it harder for us to be influenced from the outside, from feeling the sensations in our body and emotions consequently. And you try to focus, you tell yourself in your mind that I am my patient. This is an affirmation which directs your attention to what you are feeling, directs attention to this situation, your empathy. And so once you are relaxed and you have told this information, you try to focus on what actually you are feeling, what has changed. Because there may be a vague change in your sensations, for example, an increased weight in your limbs, or for example, you may feel something on your heart, or for example, you may feel a certain emotion like anger or something like this. And this will be a vague idea, a reflection of what your patient feels. Of course, it is not ideal copy, because it distorts through your own ability to sense things. And once again, I told you, this should be trained. So at first, you may not even understand what you are doing. This is a very effective method. If, for example, your patient doesn't give you enough details, if your patient is trying to lie, if your patient is, for example, out of contact, and you need to get at least some vague idea about what is happening with them psychologically. So you can use this method. Okay, let's proceed with the disturbances. We have 50 slides left, so let's proceed. Okay, there is also such phenomena like sensory deprivation and compensation. So compensation is when our system of analyzers becomes much stronger, and we rely on it instead of the deprived sensory system. For example, if you are blind, we rely more on our touch for reading books, for example. Or there may be a sensory deprivation when, for example, there is a diminished signal from a certain analyzer, if any. And it is a very interesting thing because there is a certain syndrome called Charbonnet Syndrome. And this syndrome occurs when there is a total diminishment of signals in certain analyzers. So there was this case when the grandma was admitted to the hospital because she saw a very big dog walking around her apartment. And everything would be good, but she was blind. She couldn't see this dog physically, but she saw it. So that's Charbonnet syndrome. Once again, remember your deaf grandmothers and grandfathers. They may tell you the things that you have told to them, in their opinion, which never happened. You never told those things, but they remember it. They have heard them because they have very bad hearing. So here is that. Also, pain. I have already told you that the pain, even if it is very unbearable, it is usually a signal of something. And pain depends a lot on our attention. It is a subjective feeling. Okay, let me phrase it like this. There are two components to the pain, the sensory one and the emotional one. And these are different pathways in our brain. So we can influence our subjective viewing of the pain by shifting our attention. When we are talking about hypnosis, for example, hypnotic analgesia, which can happen if you are a good hypnotizer, it is merely a shifting of the attention to a certain other thing for the person. So what I mean by this, when I was having practice in a hospital, and I was working in the ward where there were frequent examinations of gastrointestinal tract, mainly endoscopic ones, you can imagine how unpleasant it was for the grandpas and the grandmothers having tubes sticked in their rear end. So I understood this comfort, and I was using simple hypnotic techniques with them. So I was coming up to them during this procedure. I was asking them, do you remember how your house looks like? Do you remember your pets? What are their names? How they smell? How are they to the touch? What color are they? So I was directing their attention away from the painful sensations they had to the more pleasurable memories. And all of these old people were very thankful to me afterwards, because this way procedure was much faster and much more comfortable for them. Also, about smells. So I have mentioned before that having foul smells, like not having, but having to smell foul odors is not a problem for me. So why? When I was a medical student, I was very lazy and I didn't want to change clothes into the outer clothes when I was walking around between the campuses of the university. But the problem was that in the winter it was very cold, but I was still lazy, and it was cold, but I was lazier than the cold outside. And therefore I just started to remember how the heat of the summer feels on the skin. And I was walking around in the same cloak between the departments. And it worked. Subjectively, I wasn't feeling the coldness. Objectively, if I lie down in the snow, I would freeze to death. But subjectively, I would feel the heat. So here is the trick with the temperature. The same trick can be done with odors. So when I was on the sections and there was a very hot summer and the section room was literally filled with people up to the ceiling, and many of them were decomposed in a very bad state. If I didn't want to smell that, I would just remember how my favorite perfume would smell like, and it would substitute the smell of the corpses. So, an easy trick. Therefore, I didn't even need that advice with closing up my nose in front of the patient. I can just substitute my senses. So here is that. Okay, so how do we study perception? Of course, we observe. So if the person sees something which is not real, most likely it would reflect in their behavior. Also, there is introspection method. So when you are studying yourself, what you are sensing, and it lies at the basis of the substitutional perception. Also, questioning. So when the person, for example, sits still, but you still need to know what they see. And also you can have different audiometers and like special instruments to check elementary sensation, but you learn those on the neurology course. Okay, so here is this. Okay, before we proceed on to memory, let's have a little break for 10 minutes and then we'll continue. are moving to another room, so I'll close the camera, and in a minute everything will be ready. Ну, пока накрыть.
Какую-то таблетку выпить.
Таблетку?
Таблетку.
Таблетку куретку.
Это лучше такие мелкие.
Это такие мелкие? Просто не хочу долго собирать.
Ну, вот видишь, уже собираться на них собрать. Придумала рассказ. Завтра
Всё,
будет
я
так.
довольна, я не способна вот это.
Не ставить болеть? Не будет здесь мешать?
Нет, это не будет. Оно же снимает туда.
А я хочу на левину работу посмотреть.
Так тебе будет неинтересно, я же буду на английском болтать, ты же английского не знаешь. Ты же не поймешь, что я там болтаю.
Пожалуйста.
Почему здесь, пожалуйста? Ты будешь мешать? На водички попил и пошли в комнату.
А как я буду?
А там это на тебя рады смотреть будут всякие дядьки незнакомые.
На, попей водичку, пошли.
Вдруг дядька придет, тебя в мешок посадит и занесет с собой.
Чужой дядька.
Скажет, хороший сыночек, хочу себе такого, и все.
Да, чужими дядьками разговаривать.
Да, поэтому не надо.
А он тебя знает?
Я знаю его, а он меня нет. Я им оценки ставлю.
А кабаценты?
Нет, надеюсь, что нет. Ну, не все из них, некоторые, да.
Скажи английский. А ну-ка, алфавит скажи английский. Спой песню про алфавит.
A, B, C, D, E, F, G, H, I, J, K, L, M, Q, R, S, T, U, V, W, X, Y, and Z. Now you know my ABC and start on using.
Здесь мне неправильно.
И пука. Будет потом петь, мне кажется, на всех языках.
Я с ним английским языком начала заниматься. Короче, он начал путать все буквы подряд. Украинский, русский, знаешь, такая
Бывает,
перемешка.
Там
Ну,
говорят,
остановиться.
да, говорят с определенного возраста.
Да, если, ну, знаешь, она у него вроде как идет, но начинает путать все подряд.
А у них сейчас период такой, они же всего впитывают, типа, ну, нужна система, потому что иначе типа
Ну
перепутать.
да, потому что, как сказать, что в семье должны родители разговаривать если знают, то типа хорошо, на двух языках. То есть я говорю на русском, Юра бы говорила на украинском, она не знает. Поэтому, знаешь, у нас проблема. Я не могу на всех языках разговаривать, чтобы он был вообще туда. Как я начала, я понимаю, что он все, я начала это путать все. Все, пошли.
Так, все.
Не убийца здесь. Красить только надо свет.
Okay, sorry for this. I needed to readjust everything. You might have heard English alphabet. That was my nephew Very nice and talented boy. Okay. Oh my God. These slides are horrible. 1 minute. Okay, now it is much better. So let's continue. We have very little slides left. Okay, so now let's talk. 1 minute. My throat is hurting. Okay, so now let's talk about the memory. So memory is the mental reflection of the reality, and it operates on different functions. So the memory process consists of memorizing experience, then storing experience, then actually remembering or retrieving the experience, and also forgetting. And you shouldn't forget about forgetting, pun intended, because the information in our brain doesn't get forgotten in total. It gets suppressed to the consciousness, and this means that the person may not be conscious of certain experience, but this experience would manifest in the emotionality of the person, in the non-verbal gestures, in the non-verbal communication, and also in the bits of behavior. So, for example, the person who has undergone sexual assault by a person of certain sex, for example, would react with the emotion of fear towards people of this sex, even though, for example, these same people will not be aggressive towards the person in the moment. But this memory of having the male, for example, offense you is still vivid in the person, even if they are not conscious about its experience. So what would be wrong with the memory? Oh, before that, so there are different types of memory. So there is motor memory, affective memory, imaginational memory, also verbal logical memory. And I have named those in the succession from the older ones to the most younger functions. So verbal logical develops the last one, and the motor develops the first one. Also about emotional memory, it may be an important differential factor, because, for example, in dementias, the person who has dementia may not memorize you on the first day, and on the next day they will not remember your name and who you are, etc. But the emotional response would be as if they already know you. So effective emotional memory is much more durable than the verbal logical one. Okay, so memory also can be divided by the volitional activities. So there may be involuntary memory, when you direct your will in order to purposefully remember something, or voluntary memory, or involuntary, when you just remember something because it was a sudden impact on your nervous system. What can be wrong with the memory? There may be too much of the memory, too little of the memory, absence, and a distortion. So too much of the memory, hyperamnesia. Hyperamnesia happens with people in extreme situations. For example, when the person may remember all the details of the car crash they have undergone if they didn't hit their head. So here is that. Or, for example, the person who had a traumatic experience and may remember all the details of the clothes of the offender. So here is that. Or there may be hypomnesia, when there is a decrease in the memory. And another experience, example here is, for example, another instance here is that the patient who has undergone a psychotraumatic experience, instead of remembering all the details, they omit certain parts of the experience. For example, the person may say that, I remember the clothes of the rapist, but I do not remember what I felt at that moment. I don't remember the face. I only remember the green shirt, for example. There is a short story called I Have No Mouth and I Must Scream. And one of the main characters was tormented by her memories of being raped in the elevator. and her rapist was wearing yellow, and this woman developed the fear of yellow as the result. So here is that. Also, about memory overall. Memory is prone to distortions, always, because our memory is constantly reconstructed on the basis of our current state. And this means that, for example, if now we have convictions which are contrasting with the ones we had, for example, 5 years or 6 years before, usually people just forget the fact that they ever had the opposite convictions, and they just say, I was like this all my life. That's not true. People change. The person you are right now will be dead by tomorrow because you'll be another person. And there is a lot of factors which influence that. And this is important because, for example, when we are judging people with illnesses, many of them may not remember the time they were healthy. For them, it feels like eternity, like they have been like this all the time. Also, I have seen this a lot in the LGBTQ community, for example, when people say that I have already had this, I have always had like this preference or like this gender or stuff. For some of them, this is definitely true, and you believe them and you understand that yes, this is true. But for some of them, when this statement is coupled with the signs of the psychic trauma, you understand that most probably they just forget about the period when it was different. Because I would say neurotic part of this, like this, not all of them. But the vast majority of people I have encountered in my practice as a psychiatrist, yes, so obviously they had some problems. Usually you see that most probably it was the trauma which triggered a variety of behavioral changes in the person in order to cope with these emotions. And there is nothing bad in them not remembering that they were different before, because what changed them was just so painful, they don't want to remember about it. If the patient is, if you notice these signs, and this is relevant for many illnesses, if you notice a sign of an illness, and this illness doesn't have an imminent danger to the life of the patients or to the lives of the people around the patients, and the patient doesn't present it as a problem, they don't see a problem here, and it doesn't affect the cause of the development of the another illness, for example, which they present as a problem, do not get into that. Patients should be allowed to be people with their flaws and with their strong things and with their weaknesses, and sometimes with certain bad things of their life, if they choose to. So if they do not present something as a problem, do not try to cure them of everything. This is a very common, I would say, desire for many doctors, me included, to like to make the life for the patient the best they deserve. But if the patient does certain things in order to remain in certain, but they do not understand this, they do not want to change this, they will oppose your tries to change it. Maybe let them be, because that's their choice as people. Even though personally I have a bitter feeling when I see that this choice is not conscious. So the least you can do, if you want to help in this situation, the least you can do, or I would say not the least, but the most you can do, is just to make this choice conscious, to explain to the person that this is what happens. If they accept this, okay, and this makes their choice conscious. If they do not accept this, you have done whatever you needed. You have done already what you can for this person. When the time comes, if they feel that they will need your service for this particular reason, they will refer to you. If they won't, it is their choice. It is very hard to accept, but you cannot save everyone. Most notable if you know those people. Okay. So, about amnesias. Amnesias can be divided in a variety of things. So, amnesias is when the person is not remembering stuff. So, it may be retrograde. So, events preceding the start of an illness are forgotten. or it may be anterograde. The events from this, starting from the onset of the illness are forgotten. Or anteroretrograde, both the preceding events and succeeding events after the onset of the illness are forgotten. It may be fixating. The person cannot memorize new experiences. And I have had these patients. So I was based at the 4th Chronicle Ward for males, and there was this patient with Fixative Amnesia, who was a boxer previously, and due to his head traumas, he had developed this syndrome. So when I was talking to him, he mentioned that he had a child. So I asked him the age of his daughter. He told me that his daughter was 28 years old. And when I looked through his papers, I discovered that actually his daughter was 28 years old. So you can imagine at which point in time he basically froze. And it also influenced his mood, because he was always very jolly, he was euphoric, he was happy, he was always thankful. And that was due to him not acquiring new experiences, which means that he doesn't lose anything in his life. He doesn't know what it means to experience grief, because he is never lost in touch with things. It may be very hard for the when they have amnesia in their family, because it may feel that you are losing the person, you are losing the emotional connection between you and that person, your shared memories. My psychotherapist had a grandmother who was suffering from Alzheimer's disease, and my psychotherapist was 27 years old at that point. So the grandma came to their home and started asking her daughter, the mother of my psychotherapist, where is the cradle for the child? So she remembered her grandson being a toddler, and that's why she asked. And when she saw her grandson all grown up, she asked the mother, "Oh, who is that handsome man?" So she doesn't know that's her grandson all grown up, and she will forget it if told. Very, very fast on the next day. So amnesias can be progressive when these disturbances become worse and worse and worse, and more memory is lost, usually starting from the most recent one and finishing with the most distant ones. And not progressive. When, for example, the person hit their head after falling from the tree, and they don't remember what was happening before the head trauma, like immediately before. And that's all. They do not lose their memory even more throughout the course of their life. Okay, now about distortions. So there are 3 kinds of distortions of the memory you need to know: pseudoreminiscences, confabulations, and cryptomnesias. So what's the difference here? Pseudoreminiscences are the easiest to understand. So the person remembers, like the memory of an actual event exists, but is attributed to the wrong day. So that very boxer tried to explain to me that he was running on the stadium on Monday. But the thing was that on Monday he was in the ward, and on the previous Monday, and the Monday before that, and before that, because he had been in the hospital for 3 years, but he doesn't remember. So when he was a boxer, actually, like starting like a real sportsman, he indeed was training on the stadium, but it was so long ago. So that's pseudoreminiscence. When we're talking about confabulation and cryptomnesia, both of them have in common that the memory is false. It doesn't exist, the event they remember doesn't exist in their personal lives. But what is wrong here is the element, like what is the difference between confabulation and cryptomnesia? Confabulation originates without any connection to the external stimuli. There is no problem with attribution. It just appears as a fairy tale, for example. And when we are talking about distortions of the memory of people who are healthy, we are also talking about confabulations when they just imagine things. And cryptomnesias have the fault of attribution towards oneself or other selves. So there is the boundary between our psyche and psyche of other people is blurred. So what I mean by this? So while confabulation looks like a fairy tale, for example, the patient remembers that they have been on the moon on Tuesday, And this is not a hallucination. They don't see themselves on the moon, but they remember. They have the experience of being there. They can tell you the details because they remember them. That's confabulation. And talking about cryptomnesia, usually the event exists, but not like, okay, let's talk examples. So the first example is, for example, I read a newspaper, and in the newspaper I see the report that somebody won the jackpot in the lottery. And I start telling everyone that that's my jackpot, that's my win, because I remember that I have won this money. So I took a very happy memory from other person and attributed it to my biography. So now it is my memory. When we are talking about other example is when, for example, sorry for the tautology. So, for example, I know that my wife is cheating on me, but I'm telling, like, my wife is loyal to me. It is their problem. So here I take an event from my life which I despise, which I don't want to remember, and I attribute to another person. So it is theirs. Cryptomnesias are often at the base of plagiarism, but this plagiarism is not done with immediate benefit here, and this is like another factor. When the person is ill, there is no clear benefit to the illness, it just happens with them. There is still some kind of benefit, but this link is not obvious. It is so much processed by the psyche that you do not see it immediately. It is very hard to find this link. And so, for example, the person who is plagiarizing out of cryptomnesia would claim that they are the author of a news report, for example, in some distant village where only 5 people live. So there is clearly no practical benefit for this, but they still claim that this is their work. And the person who is plagiarizing because of personal benefit would, for example, draw a Mona Lisa, like paint Mona Lisa for the second time. Or they will write Harry Potter and claim that that's their book. And while being interrogated, the person with like pathological cryptomnesia, who is ill, they will emotionally fully believe that's actually their deed, that's actually part of their memory. While the person who is just lying, you'll see that they're nervous. You'll see that they are lying. Their emotional response, non-verbal emotional response, would indicate that they have some control over this process. And that's like not true. Okay, now about thinking. So what is thinking? Thinking is a mental process, and it is also mediated reflection of objects. Also, thinking is referred to the conscious process of translating our unconsciousness to others. So, for example, when you are thinking, it is an illusion that you are thinking by words and sentences. No, in our inner world, everything is based on sensations, on emotional states. And it is when we try to convey these states into words and to share them with other people, the thinking comes in place. When we try to predict something else which exists outside the boundaries of our immediate perception and sensation, it is when we use thinking. It may okay, what about this? What about that? Yeah, also about the memory. How we test the memory? The memory can be tested by the variety of tests. For example, 10 words test, when you name 10 random words and the person repeats them. Also, throughout the conversation, you may name your name, and you may tell the patient your name and then ask them to repeat this name after a while. Also, there is story reproduction. When you tell a short story, the patient should reproduce it. And also a part of Lexless intellectual test. The subtest where you name rows of numbers which are increasing. So at first it is 3 numbers, then 4 numbers, 5 numbers, 6 numbers, and each row is marked with a certain amount of points. So the more points you get, the better your memory is. So that is the difference. The examinational methods of the memory. Sorry, I'm a little bit tired already. cannot live without tea. Okay, so thinking. How we can classify thinking? Thinking can be divided into visual aid and semantic aid. So semantic it is thinking based on meaning on concepts, and visual aid is based on the form of objects and images. Also, thinking may be intuitive, based more on the senses, on the gut feeling, and it may be analytical, having links between reasons and consequences. I won't be talking about forms of thinking. Mental operations, well, analysis and synthesis are opposite functions, opposite operations. So when we analyze something, we divide the whole into its parts. When we synthesize something, we unite the parts into the whole. And when we generalize, we widen and share the properties of some part onto the whole. And this is very important because a lot of our patients like to say, I have always been depressed. Or for example, people always offend me. When they say awfully, always, it is a minimum of 3 instances. Because due to generalization, we tend to spread these instances onto the whole, which will be false in most cases. You may see this in the perception of the other countries' people, civilians. So we generalize that if warriors offend us, if military people kill us, then it means that civilians also do this. And that's not true. Not all of them like this. But it is very hard. It is easy to generalize. It is a basic function of our psyche, which makes it easier for us to live. So here is that. Also, disturbances of thinking. So what can be wrong with our thinking? A variety of things, actually a very big variety. So I will be stopping only on those which have more significance. Alternating processes of internalization and enters consciousness again. So it intrudes your consciousness. The person suppresses it again, and it intrudes. Suppression, internalization, suppression, internalization, alternating itself. And in this way, we see that the thought becomes obsessive because the person fights against the easiest way actually to get rid of this impulse is not to try to suppress it, because this will just perpetuate this end of cycle. Even if this thought is as having an intercourse with a dog, because obsessive thoughts may be various and very bizarre. And this is another trait of the obsessive thoughts. Usually people who have them do not tolerate the very content these thoughts have. Okay, also there may be histrionic reactions. And histrionic reactions usually have a tone of theatricalness, of show-off behavior. Histrionic reactions only manifest when there is somebody watching you, because it is a certain way of reacting, a certain way to attract attention towards you, mostly to help you. Also, histrionic reactions should be aesthetic. So people who are giving you a histrionic reaction, for example, they're trying to slash their wrists in front of you, their cuts won't be deep. They don't want to kill themselves. They want to blackmail you into doing something to solve the conflict they're in by this histrionic reaction. And histrionic reactions do not only involve suicidal threats and like fits of anger when the person plays around in the mud, but their face is always clean, of course, trying to get what they want, like those fits children throw. I thought that I heard airplanes. Those fits children throw in the shops, for example. It may be in the form of the stupor, so the person doesn't move. But obviously, if there is a danger to their life, they will move very actively. Or, for example, in the form of dissociation from a certain part of their from a certain function of their psyche. So, for example, the person suddenly stops moving and they say that I am paralyzed, for example, while actually organically you see that this function is not disturbed. Like it doesn't correspond to the usual nerve going around the body. It doesn't correspond to the organic disorder. So it is purely functional. The person may forget certain things, dissociate from them, and you fully believe them when they say that they have nothing to do with this certain action, because they actually believe that they haven't done it at all in their life, because they are dissociating from the memory. The memory gets repressed once again. Okay, so also suggestiveness. Suggestiveness is a trait when the person is easily influenced by the outside factors, and this is a very good source for the inducing of illnesses. For example, there was this case when there was this grandpa with catatonic schizophrenia, and he was falling into stupor frequently. And when the ambulance arrived to his house one day, they found not only the grandpa, but also his granddaughter being in stuporal state. But if we are talking about the grandpa, it was catatonic schizophrenia. If we are talking about the girl, she was in histrionic stupor, because she was induced by the grandfather that she can also have this stupor, so she acted upon it. Delusional ideas spread very easy like this, and you may see it with propaganda, for example, how it works. People become molded by the things they see each day. They become induced by these things, and once again, the more relaxed you are, the better these ideas come to you, and the faster. Any suggestion should find its way out, because this is certain intention. But everything which is not specified by suggestion is up for you to decide. It helps, for example, if you are, oh my God, that's an animal. Okay, this helps when you are being influenced by other people to do, for example, something you don't like. All the conditions not specified, you can decide for yourself. For example, somebody tells you to jump. It is not always to jump from the roof. You can jump over the fence, for example, and that would count. But you need to know that suggestions always find their way out. Always. Okay, affective thinking. So I have already told you that some psychopathological syndromes are affected by our mood. So when thinking is affective, it is not based on reason, it is not based on logic. The person just tries to find the things which enhance their mood in this certain way. So for example, if I'm feeling paranoid and I'm scared of other people, I would see in their actions that they are a threat to me. I would find out all these signs I deem aggressive from themselves, because I'm inclined to find them. My thinking is effective. I was contacted by the patient, for example, whom, well, she is actually healthy, but she was very prone to affective thinking. So she became scared one day that she has schizophrenia because she had hypnagogic hallucinations. These hallucinations occur when the person goes to sleep, and can happen from the variety of reasons. Once again, because I was sleep deprived, I also have these hallucinations, and they're long lasting for me, because you need to sleep. Okay, and so this woman complained of this symptom, and she was like, I have schizophrenia, right? I'm going mad. I was reading all the all the sources, and now I'm convinced that I have schizophrenia. So all her thinking was actually perpetuated by her fear of becoming a burden to her family, because for her, being schizophrenic was associated with being helpless, with being a burden to other people. So that was at the base of her fear, and she was not schizophrenic at all. But it was very hard for her to think of alternatives, to think about all the symptoms contradicting that she is insane, because she was seeking out the symptoms which made her insane. I told her this directly. You will find symptoms you look for, because you look for them. Okay. Here is that. Okay, now about, also about the patients. Sometimes patients may perpetuate their illnesses because of the secondary benefit associated with that. And I have seen the person who was actively trying to convince me that he had attention deficit and hyperactivity disorder. And this is a disorder. When we are talking about the level of an illness here, this disorder can manifest by the disorders of attention and impulsivity, which are dangerous to the person. So the person may, for example, get under the car on the road because they cannot wait for the green light. The person is so inattentive that they, for example, miss threats around them. Or, for example, the person, sometimes they get hyper-focused when they are stuck on some stimulus. And while being stuck, for example, the person may miss their meals and may not sleep, and they're unable to control the state. So it is chaotic. That's the level of illness. And that guy, he didn't have any disturbances of attention whatsoever, but he was inclined in telling me that he had those, and he insisted because he wanted to have this label of having an illness, because when you have an illness, you have an excuse to blame things on this illness. And this is a very, very big relief for a lot of people who are scared of responsibility. I'm not telling that if you have an illness, you are running from the responsibility consciously and you are like using it all the time to justify you. Actually, the healthy position is that, yes, I have a condition, but it doesn't get in the way of my function. I'm doing my best to function on a higher level. And people like that guy, they just come with excuses each time when they don't want things to go a certain way. So, for example, he was telling me that he was hearing some critics from me. And, for example, the very next minute, he was like, oh, what? I didn't hear you. It is ADHD. So there is a delay in his reaction, and there is a clear secondary benefit to his reaction, and I saw emotionally that he heard me and he understood what I have said. It's just that he doesn't want to hear it. So that's the behavior which is malignant. Okay, and you need to be aware about it, because there is a lot of similarities, especially in the field of psychological health. For some reason, people think that psychology is not serious and we cannot measure psychic functions, which is obviously not true. Okay, so how we judge the disturbances of thinking? We judge the disturbances of thinking by actually observing the person talking about certain things. So which things they talk about first and foremost, and then also the rate of the speech, so fast or slow, because it reflects the speed of the thoughts and associational processes. Also, yes, links between the ideas, so associations of the person, and structure of the sentences, if the person is able to form full sentences and full words. Okay, now about intellect. So how many slides we have left? Oh my god. Oh, well, not much, 20 slides. Okay. So about the intellect. Intellect is much more than just mathematical, I would say, education abilities of the person. It is ability to perpetuate goals you have set for yourself, to plan things, and to gather experience and acquired knowledge. For the intellect, there is a variety of tests. Most popular ones are Raven's matrices, which you will find in the presentation. And these matrices are actually only testing your ability to see patterns, because basically the task in Raven's matrices is that there is a pattern and you need to fill it with the last tile. So I don't really like this test, because I think it is not versatile enough for me. So when I'm trying to test my patients, I prefer another test called Lexless Test. So when we are talking about Lexless Test, 1 minute, I'm thinking. Okay, when we are talking about Lexless Test, it is divided into two scales, verbal and non-verbal, and it tests a variety of psychic fields such as memory, thinking, vocabulary, and stuff, even spatial orientation. And that's why I like this test much more. Well, now about attention. Attention is based upon many factors, but most importantly is on our view. So how we are able to direct our psychic activity, our perception, our sensations. Attention can be involuntary, voluntary, and post-voluntary. Post-voluntary means that the person notices certain stimuli, and even if the person is occupied with some other activity, they just cannot get rid of the thought of the stimuli out of their head. So this is post-voluntary. What can be wrong with the attention? So I have already mentioned hyperfocus, so when there is too much of attention, and there is also diffusion of attention, when there is too little of attention. So about hyperfocus, an example of hyperfocus in ADHD, for example, would be there was this patient in America who never could concentrate his attention apart from the times when he was doing sports. So during sports he would become hyper-focused. And so there was this instance when he went to the basement to do sports, and he was retrieved from the basement in 3 days by his parents because he was just doing exercise all this time. He was malnourished, he was dehydrated, he was rushed to the emergency care because all this time he wasn't having any rest, he was just exercising. This is what hyperfocus means when we are talking about illnesses. Yes, so here's that. Also, when we're talking about diffusion of attention, the person is unable to keep up with certain activities, they are unable to keep up with their goals, and their quality of their work suffers because of their inattention. Okay. How do we test attention? There is a variety of tests. For example, one of these tests includes colorful dots, which the patient should count without pointing them. So we check the concentration of attention in this test. There is also proof test. It is a wall of text at which the person needs to cross out certain letters. For example, cross all A's. There is also a modification of this test called Untitled test, and there the instruction is a little more complex. So cross all A's which come after C's before B's. There is also shortest table, which looks like a table with numbers jumbled all together in random positions, and the person needs to find all the numbers for the fixed time for fixed time. And we measure the time they have spent on it 5 times, and there are formulas, equations we use in order to check different aspects of attention, and after that we can say if the person has problems with attention or not. There is also crippling test when the person subtracts numbers, for example 3 plus 2 or minus 3 plus 9 minus 1, etc. So here we test both operational memory and also the attention. Okay, emotions. I have already talked about the nature of emotions, and you need to understand usually emotions are very powerful, and they start as sensations. They start as certain balance of neuromediators in our brain and also hormones in our body. So those people who say they do not have any emotions, they lie, because you always have hormones in your body if you are alive, at least, and this influences your behavior and your emotions. So our emotions they perpetuate all the fields of our behavior. So you see the expression on the face of the person, you see the dilation or the constriction of their pupils, for example. You see how they move, you hear how they speak, the rate and the tone of the voice. For example, my emotional response is very restricted, and so you may have noticed that I use volume to modulate my intonation, but I do not use intonation itself because I don't know how to do this. Well, I'm just like this. So here is that. You will see the emotion also, well, indirectly in the way the person is presenting themselves. So the person who feels nice, who feels good, most probably will be putting on makeup, will be dressing well, and the person who is feeling depressed will be unkept. So here is that. Also, autonomic response, pulse, also breathing rate, perspiration, all of these matters. And there is always an integrity in a healthy person. There is always an integrity of these factors. If the person, for some reason, loses the integrity between these, for example, the person expresses sadness by their facial expression, but is always also very agitated, or for example, if they are happy on the words, but they are obviously depressed by their non-verbals, there's something wrong with them. If the person is euphoric, and you see that they are smelling like a homeless person, there is something wrong with the person, most probably. Also, some patients, due to different illnesses, may lose emotional resonance with other people, but this doesn't happen abruptly. And if you have noticed, healthy people usually move their faces a lot, both at their experiences when they're talking about their own experiences and as the reactions to other people. When the person loses this resonance, first of all, they lose their empathy, so they stop reacting emotionally on other people while still having the emotional response towards their own experiences. And when we go further, for example, for patients with emotional bluntness as a result of schizophrenia, they will not move their mimic muscles even when they are talking about their own experiences, but they still have feelings, they still have these sensations in their body, but they are unable to connect with them because of the illness. Okay, so what can be wrong with emotions? For example, the person may be euphoric. The euphoric person is happy and jolly, and nothing can change it. You may say to them, you know, the world is ending right now. Like, your family is dead. Your favorite cat is dead. The person wouldn't be perplexed by this. They will still be happy. They will be laughing because they're feeling euphoric. So that's euphoria. There is also dysphoria. Dysphoria is gloomy, angry, gloomy, like sad mood, such melancholic mood, which starts abruptly and lasts for a certain period of time and then fades away. Usually it is a common situation among people with epilepsy. Also, the person may be emotionally mobile, so their emotions change very quickly, but there is always an objective reason for the emotion to change in a certain way. So that is emotional ability. There may be also ambivalence. So you may remember that some teenagers say that, for example, I hate my parents, but I also love my parents. That is healthy ambivalence, because they do not feel those emotions at the same time. They're alternating themselves. Like something always is always inhibited in the unconsciousness, and something is in the conscious mind. But when we are talking about the pathological ambivalence, mainly about people with schizophrenia, they feel the contradicting emotions with the same tense at the same time. So they are both in the consciousness and not in the unconsciousness. And therefore, this affects their behavior. Their behavior becomes contradictory. They may start hugging you, but also push you at the same time, because they cannot alternate between those states, and they cannot decide what to do, how to behave. That's ambivalence. Okay, apathy. Apathy is the absence of the mood. The person may not do anything, not because they do not have energy to do so, but because they just don't feel like it. On the contrary, the depressed person, which feels very sad, they usually do not do anything because they don't see the sense in doing anything. They do not have energy to do anything. Even if they really try, really want to, they just can't. That's relating to the experience of the patient to the situation. So, for example, the patient is laughing on the funeral, or for example, crying on a wedding, and the difference from the tears of joy, for example, is that the person with the tears of joy is aware that this is a strange reaction and they can stop. The person who is like this because of an illness cannot stop because the illness is chaotic at its start when the person is not treated. Paramimia is when the person's mimical expression becomes disorganized. So, for example, the person may smile with their eyes but be very sad with their mouth. And you may say that like this might happen with some people, for example, the ones who are lying, they are not smiling with their eyes when they are smiling with their mouth. But the problem here is in the regulation of the movement of the muscles. And if you are familiar with motor units of face, you'll see that this movement doesn't correspond to any full emotion. It is a mix of emotions displayed at the same time, and the person doesn't control it. So it looks very scary. Okay. Other emotions, when they're unconscious, they're stored, once again, in the body. And there was this case in the psychotherapy when there was this woman trying to cause the catharsis of emotions, so to release certain emotions. We have worked with her. She went home, and on the very next day, she called the psychotherapist and complained that she is paralyzed. She cannot walk. Actually, the thing was that she could move her muscles, but the problem was that her tonus was so much more relaxed that she was unable to stand on her own. In a couple of hours, she was fine, but this is due to her emotions being released, and so the tonus of her muscles changed, and she relaxed very quickly. She was just not used to this relaxation, and therefore she had to learn how to live with this relaxation. So that's why you can imagine how many people may refuse to change their pathological impulses and their pathological habits because you may try to learn to live anew from certain conditions. Here is that. Okay, now about the factory evolution of sphere. So how we move and what for we move. I've talked about this. So what for can we move? Because of our needs, because of our drives. Our drives can be biological, so which are instinctive or lower. Need for food, need for self-preservation, including maternal instinct and including instinct for copulating, because you are basically perpetuating yourself into children. Also, yeah, self-preservation, I have talked about it as well. And there are also social or higher needs, such as like self-realization, finding your place in the society, like also getting an ideology and stuff. What can be wrong with our drives? We can have problems of our will. So there may be too much will, hyperbulia, or too little will, hypobulia. There may be also the absence of will, abulia. But usually abulia comes with apathy. You have no emotions, no mood to do anything, and no will to do anything, no inclination. So when we are talking about hyperbulia, there is too much inclination in one direction. It is usually pathological. For example, I may feel paranoid, and because of this, I will change places where I live because I know that people are spying on me. So I'm going to another place. So that's hyperbulia. Hypobulia is the lack of will, and that guy who tried to imitate ADHD, for example, had the lack of guilt, of will. Okay, sometimes hyperbulia may be useful when we are trying to raise the discipline in our patients. And that's another thing you need to understand. Discipline helps the majority of our patients because discipline helps you to find an anchor in your life, a certain state at which you can return when everything is in chaos. And this state becomes your starting point for any other changes in your state. This is important when we stumble upon illnesses, because usually these illnesses are chaotic. The person doesn't know how to live there. But if they have discipline, they can return to a certain state at which they feel much, much more grounded. And so there is a certain exercise used to raise the discipline of the patients. It is called inflexible determination. I would recommend it to everyone. So how it is done? You choose a very easy action. For example, having a glass of water each time when I wake up. And you do this action each day without missing. I forgot the word. Regardless, yeah, you do this exercise regardless of the environmental factors, regardless of the conditions. So, for example, the meteorite may be falling on the city, but you need to have that glass of water, and you go and you drink that water. The house may be on fire. You are drinking the water, so the whole world may wait when you drink the water. So that's this inflexible determination. It is very hard actually to do for very prolonged periods of time, and at first you may not understand how this helps you. After 3 or 4 months, this becomes a compulsion, and now you cannot go without this habit. But this helps you to later form other habits which may be harder and which require the will, because you're training your will in this exercise. Okay, so how do we research? Yeah, also about emotions, there is a variety of tests which can test emotions, such as method of color choices by Usha, when there is a selection of 8 colors which can be interpreted, and the patient chooses these colors in succession from the most pretty to least pretty. So they arrange these colors. Also, like thematic apperceptive test, which includes pictures of people doing stuff, and the patient needs to interpret these pictures. Also, what else? Hospitality scale, hospital scale, like the basic anxiety scale, also Spielberg's test, such stuff. You can find them online. They are most important for the psychiatrists than psychologists. If you want to know more about these disturbances, you may see the first 2 topics of my psychiatry and narcology course, when I'm talking about all of these in details. Some examples may be connected to one another and maybe the same, because they're just very good examples. Okay, so how do we evaluate affective evolutions here? We evaluate the patient's pose, tempo of speech, like their look, appearance, from which we judge which needs they perceive, like prosecute. Also, we ask them, and we may also use different examinations, like experimentally psychological, laboratory, and other investigations. Also, like observe the patient throughout the day as well. Okay, consciousness. Consciousness is the high activity of reality reflection, and it basically has to do with awareness of yourself and to the surroundings of the person, their alertness to the stimuli. So that's why we are talking about self-consciousness or auto-psychic orientation, and consciousness about surroundings. Our psychic orientation. Okay, so I will be talking about consciousness properties. But what you need to know as psychologists about the signs of consciousness disturbance. Just talked about this. So there should be estrangement from the surroundings, disorientation, and amnesia during the period of this disturbed consciousness. And this is important because a lot of people who commit crimes try to blame it on the periods of altered consciousness. But if they do not have, well, even partial amnesia about what has happened, if you see that there is a plan to the actions, for example, the person killed another person and then tried to rub off the blood, or for example, if their fully energized after this period and not asthenic and not weakened. This is not a real disturbance of consciousness, they are lying. So what can be wrong with the person? The person may be in a stunning state, and this means that the threshold for the stimuli is raised, but you still can talk to the person. It's just that their reaction is delayed. There may be sopor, when the person is sleeping and it only wakes up when you inflict pain on them. In coma, the person loses their surface reflexes. There may be a pathological reflexes, right? There is mydriasis of the eyes, and the person is out of contact on the pain. And there may be also lucidness of the consciousness. So usually a consequence of different psychotropes ingested when everything is just too colorful, too and now let's talk about the quality disturbances. So when the consciousness isn't, so there may be delirium. In the delirium, the person loses our psychic orientation. So due to the hallucination, the person may not understand where they are. In these hallucinations than in the real world. The person may become aggressive in this, and the delirium usually worsens to the evenings. Throughout the day, the person just has this anxious, anticipating mood that something it has changed, something will happen. But they perfectly remember who they are. They are able to orient in themselves, so auto-psychic orientation isn't affected. When we are talking about on-roid, here, unfortunately, the person loses both the out-psychic orientation and also auto-psychic orientation. They may not understand who they are, what are their hobbies, what are their interests. The hallucinations flood their mind, and they can only watch these pseudo hallucinations as a movie, but they do not act upon them. They are not active participants. So usually these patients are moving in the neuroid. They just watch these movies walking around in their mind. They completely forget what happens around them, apart from these visions they see. And unfortunately, on the road it can change into amnesia. So what is amnesia? In amnesia, the patient is agitated in the bone boundaries of the bed. They do not walk after they come to their senses. And in this state, their thinking is also fragmented. So they just utter separated random sounds and parts of the words which do not make any sense. This is amnesia. Amnesia is usually by people who are agonizing and maybe a very dangerous state. And there is also depersonalization. So depersonalization is the disturbance of auto-psychic orientation. The person feels as if they lose their interests, they lose their traits of character, they lose their personal history, they do not remember that they have the past or they have the future. They feel changed, something is missing, something is strange about them. This is the personalization. I have seen so there was this boy. He was flying in the space with Saturnians to the Saturn, and he didn't react to anyone. And the sad part is that the psychiatrist who was on his duty in the admission ward knew that this patient wasn't standing up from his bed for 3 months, and he didn't notify other doctors of that. So when this patient started to walk around the ward, when he felt better, he got a thrombus in his lungs and he died. As we didn't even manage to do anything because this was just a very quick death, unfortunately. Okay, so how do we examine this? Observation and interview. Those are the main things. Also, when we're talking about common stuff, you can also use neurological examinations, and there are different screening tools for comas. You'll see examples of those in the presentation. Now, Rorschach test. Okay, so also personality. Personality is a combination of certain parts. So it is our character, which is a set of attitudes towards ourselves, other people, developed objects, and our job. Also temperament, innate nervous system traits we have, and also our individual experience, which makes us a personality distinguished from others. So to check personality, we can use a variety of projective tests, for example, Rorschach's test, which is an ink blot test. You might have seen it a lot. Also, there is zombie test, when there are cards with pictures of people who are and certain traits of character they have. And also there is Minnesota Multiphasic Inventory, which is a huge test of 500 of questions, but also an effective one to check the personality traits and especially accentuations. But we'll be talking about that test on the next lesson. Okay, to last slides. The World Health Organization defines health as not only the absence of illnesses or physical defects, but as a set of complete physical, spiritual, and social well-being. According to World Health Organization, real health doesn't exist, because I wouldn't see, like, I read health composes not only from physical, mental, and social well-being, but also our role in the society. So if you are unable to play your roles in the society, like psychopaths will help individual, according to the World Health Organization. Okay, I won't be talking about mentally healthy people, because once again, it is very hard to do most of the times. Let's imagine Steve. Steve has no defects and no health issues. So he is in first group, healthy persons with normal development and normal functioning. Now let's say that Steve, for example, has like a crooked nose. So, oh no. Let's say that he has a certain heart defect, which doesn't present itself clinically, but it exists on an anatomical level. So now he is group 2, healthy person with functional or some morphological deviation and reduced resistance to sharp and chronic disease. Now let's say that Steve has diabetes mellitus, but he follows recommendations, he follows the diet, so everything is fine with him. So he is the group 3, patients with chronic diseases in condition of compensation, preserved function of the organism. Now let's say that recently the sugar level has been 20 points for Steve. So this means that he is a patient with chronic disease in the condition of subcompensation with reduced functional abilities. He is still feeling pretty well, but not for long. The next day, Steve is rushed to the hospital and he is admitted in the intensive care because he has fallen into the hyperclinic coma. So now he is group 5, patients with chronic disease in the condition of decompensation with considerably reduced functional abilities of organism. I hope Steve survives. So those were 5 groups of health. Also, certain stress we have in our lives usually serves the purpose of us to overcome it and to acquire new abilities, skills, and to become physically stronger. So usually there is a physiological adaptation, a certain change of our functionality to fit the needs of the environment within our limits and reach, without serious changes to our body, without serious straining of our abilities and power. Then there is tense adaptation, so stress is very prolonged, and now we are at the edge of our functionality. And if it perpetuates, we get abnormal adaptation, when our body, when, for example, if you know, in Japan, there was a period when little feet were very fashionable. And so women were wearing those tiny boots in order to contract their feet to make them smaller. And the longer you use those boots, the smaller your feet get, but they also get deformed. So that is abnormal adaptation, the not normal conditions. And so at this stage, the stress, a distress, the person just cannot tolerate it. Okay, so that's all for today. We'll see one another in other videos. I hope that you